Hi, I'm here with Dr. Laurence Cooper, a pediatric oncologist at MD Anderson. Hi, Laurence.
Hello, thank you for having me.
Absolutely, thank you for coming. What is the biggest difference you find with cancer in children and cancer in adults?
Yeah, that's a great question. There are many similarities as opposed to differences. For instance, I work at MD Anderson Cancer Center in Houston, Texas. And there, everybody has cancer. But only a few people, children, that is, have cancer. So, as opposed to a children's hospital, where everybody's a child, but only a few of those children have cancer.
Right.
So in actual fact, we are learning more and more that taking care of children with cancer diagnoses is very much like taking care of adults with cancer diagnoses. In other words, their tumors share many properties of the same tumors that occur in adults. Now, obviously, there are some exceptions.
Right.
But what that's opened our eyes to is that we can use essentially the data from the adult population and extrapolate down to the younger population. So because, thank goodness, only about 1 in 800 children in the United States has cancer, whereas lots more adults have cancer. There's 1.5 million Americans every year, for instance, that are diagnosed with cancer. So we can take that 1.5 million person experience and say, okay, what kind of worked for them if if adults had leukemia, and what could we learn therefore for children, and what drugs worked, what drugs didn't work, and we can sort of tailor our responses.
Right.
But I'll tell you, one of the biggest differences is that the smaller the person, the more they can take. You don't think about this, but a young person who is, in fact, even down to the smallest babies, 6-month-old, year-old, pound for pound, is so much tougher than you and I. We can actually give them, obviously, we have to accord for the fact that they weigh less.
Right.
But if you count that in, we can give them much higher intensive chemotherapy, much more radiation therapy than we could, you or I. They're just much healthier.
Right. Do you frequently see children with cancer? How frequently do you see them come back as adults with similar disease?
Well, for the most part, with children with cancer, will enter into a remission and be cured. And we're actually very lucky in the United States because we've really worked hard over these past years. The issues around global oncology, 8 out of 10 patients with cancer in the world are not diagnosed in first world economies, in developing nations.
Right.
For them, it is a much bigger problem because their childhood illnesses do essentially reoccur in the adult ages, if they can indeed get into remission as a kid, because they're just, this 8 out of 10 demographic don't have access to sort of first world medicines.
Right.
In the United States, in first world economies, we can cure a child, and for that point, they're really, I think, finished with that disease. But we do worry for them, though, because we do say a couple of things. We say, well, if you've had one cancer as a young person, maybe there's a chance you could have another cancer as an older person. And the chemotherapy we give can actually damage, just by irony, really, damage normal healthy cells. So that the healthy cells can be essentially tricked into getting a cancer by the very fact of using the chemotherapy to cure the first cancer.
Right.
So we always encourage survivors of childhood cancer to enter into long-term follow-up programs where we really monitor their health, really for the rest of their life.
Right. Tell us a little about the success you're having with, excuse me if I pronounce this wrong,
hematopoietic.
There you go.
Yeah, it takes you 4 years of med school, and if you can say that word, they allow you to graduate, right? But hematopoietic. So hematopoietic is just a long word meaning blood.
Okay.
And hematopoiesis meaning the generation of blood or the birth of blood. So hematopoietic stem cell transplantation is biology that we use for patients who are really in extremis. Many of your listeners will recognize hematopoietic stem cell transplantation by the older term bone marrow transplantation, the boy in the bubble.
Okay.
And what this really is the taking of one person's immune system, in other words, sucking out bone marrow, it used to be in the olden days,
right,
and putting that into the patient to restore hematopoiesis, to restore development of blood. And it's that process of transplanting, that's where the hematopoietic stem cell transplantation, transplanting from one person to the other, that I do and I practice as a field. And it's a very unique specialty, and we only apply it to just a subset of children. And in fact, we also do it for adults as well. And really the patients we take care of have diseases that are unfortunately refractory to current chemotherapy and radiation therapy. They need something more. They need essentially this new birth of hematopoiesis. In particular, they need the immune cells that come out essentially of the blood that's being gifted to them from that donor put into that recipient.
Okay. Do you, with the stem cell transplantation, is it like the chemotherapy where the young patients are likely to fare better?
Yeah, it actually is. It very much, that's a great question. It actually is. We dial up the intensity for those younger patients.
Okay.
Pound for pound, they can just take more. So, and in fact, that's actually reflected in their overall survival data. A younger person, a healthy person, in other words, going through a hematopoietic stem cell transplant or a bone marrow transplant is likely to do better than a person who comes in with a lot of extra medical problems. If you're overweight, for instance, or you've been smoking, or for instance, you've not enjoyed good cardiac health, good heart health for whatever reason, or you've not enjoyed good kidney function for whatever reason,
right.
That adds up, unfortunately, for those patients. And while we can get them through the procedure, their recovery is often marked by just prolonged, in and out of the doctor's offices. We have to work with them essentially to restore their health.
Right. Now, you work primarily with children.
Yeah.
You have a different experience to doctors who work with adults.
Mm-hmm, mm-hmm.
How do you deal with the burden of a child's life in your hands? How do you cope with that?
Some days better than others. There's no one answer.
Right.
And over the years, I probably been asked that question 1,000 times, and I probably asked myself that question 10,000 times.
Right.
We're all, born with certain strengths, and one of my strengths has been that I've always gravitated to children. When I was young, and in my teens, I would always end up sitting at the kids' table versus the adult table. At the big family holidays. I have empathy for kids. I have a sense of what it is to be a kid, and I find myself therefore able to talk with them. So that building of trust, it really helps. And from that, I can essentially bring the parents into the picture and work with the parents and help them to understand the risks and the benefits of a particular treatment. And it really is trust. It's a relationship. Because, God forbid, if something happens to that young person and it really is not possible to cure them, and we can only therefore take care of them, that's a big transition for that family.
Right.
It's huge. I mean, there's no higher burden, I think, for parents than if they are taking care of a dying child. And that requires of me to be a force to provide a plan, a direction, a sense of comfort. There's no point in another weeping person in the room.
Right.
I grieve and I worry for that family, but I need to steady the ship, provide direction and calmness in a sense that we will get through this. And if it is a life-ending story for this young person, but it's done with grace, age appropriate. It's different if you're 1 versus if you're 12, for instance.
Right.
And it's done in a way that the parents have to know that they did everything. They're left. They're survivors of a child's death. And when they carry on with their lives, they have to know that everything was done, and they had turned every stone over, and they'd looked at the problem 1,000 ways. And parenthetically, I might add, just one of the things I've learned is that dying children know that too. One of the big releases for a child to actually let go and die is when the parents can say, "I'm going to be okay without you." It's an amazing moment. I try and counsel families through this and parents through this, because it really does release anxiety. Because as you can imagine, these young kids have been like, I don't want to go to the doctor. And the parents are like, "You're going to the doctor."
Right.
And they're all in it together. Everybody's fighting. The whole community rallies for these young people to get them better. And the moment it changes, and there's a sense of like, we're not going to cure you. We're just going to take care of you. The child is still in that fight mode. I'm going to go to the doctor for you, Mom. I'm going to make it possible for you, Dad, to live.
Right.
And we have to undo that. And that's it's a heavy hand, and you have to steer the ship very carefully and very thoughtfully, because there's a lot of love there, and there's a lot of support.
Right.
But if you get it right and you work with these families, you can make that passing not pleasant, but tolerable.
Right. Is there a message for our viewers, people who watch this video, that you have?
Pediatric cancer is unusual, 1 in 800. children. So most of your children, thank goodness, are going to be fine, and your families are not going to be touched by this. But it's a national problem. Let's consider, for instance, when a child dies age 5. They've lost 70 plus years, maybe 75 years now, of life expectancy. So even though, thank goodness, children are not diagnosed with cancer, the cumulative burden of those children who are diagnosed with cancer and the life years lost, if you aggregate, add it over the entire spectrum, dwarfs any other cancer. An older person, a man that dies of prostate cancer, age 85, has lost just a year or two of life expectancy.
Right.
So the problem actually is quite profound for children. The burden on our society, even though the numbers of children are essentially small, the cost to us is very large. And unfortunately, in our current economic climate and the way we're funding oncology, these types of numbers are getting swept away. We're no longer a country that is looking to solve problems. We're willing to tolerate these issues, not
Right.
solve these issues. So if your listeners really want to get involved, give money to your cancer hospitals. If you feel energized, give money to MD Anderson Cancer Center, and work to solve these cancer problems. This is real life stuff and affecting patients across our nation. And as I've said, 8 out of 10 are outside of our country's borders.
Dr. Cooper, thank you very much.
Thank you very much for having me. I appreciate it.